Assalamu alaikum. I am Dr. Rowshon Ara Khatun, Associate Professor of Gynae and Obst in Akij Medical College, Khulna. Today we are discussing about the remaining part of the topics Cesarean section. Now we are discussing about the types of operations. There are two types of Cesarean section. Number 1, lower segment Cesarean section. Number 2, classical or upper segment Cesarean section. In lower segment Cesarean section, this operation, the extraction of the baby is done through an incision made in the lower segment through a transperitoneal approach. It is the only method practiced in present-day obstetrical practice, and unless specified, Cesarean section means lower segment section. Classical section. In this operation, the baby is extracted through an incision made in the upper segment of the uterus. Its indication in present day obstetrics are very much limited, and the operation is only done under forced circumstances such as lower segment approach is difficult, lower segment approach is risky, perimortem Cesarean section. In lower segment approach is difficult when dense adhesion due to previous abdominal operations or severe contracted pelvis or with pendulous abdomen. In lower segment approach is risky when big fibroid on the lower segment, dialysis mode, and contemplating myomectomy may end in hysterectomy. Carcinoma cervix to prevent disseminated of the growth and postoperative sepsis. Repair of high VVF, complete anterior placenta previa with engorged vessels in the lower segment, then risk of hemorrhage. Perimortem Cesarean section is done to have a live baby. Perimortem section is an extreme emergency procedure when classical section is done. Now, lower segment Cesarean section. We shall discuss about the steps of Cesarean section. First of all, we should prepare the patient. Patient should be informed written permission for the procedure, anesthesia and blood transfusion. Abdomen should be scrubbed with soap and non-organic iodide lotion. Patient should be empty stomach. In emergency case, it may be by nasogastric suction. Sometimes metoclopramide 10 mg IV is given to increase the tone of the lower esophageal sphincter as well to reduce the stomach content. Bladder should be emptied by a Foley catheter which is kept in place in the perioperative period. Fetal heart sound should be checked once more at this stage. Neonatologist should be made available. Cross-match blood when above average blood loss as placenta previa. Prophylactic antibiotics should be given IV before making skin incision. IV cannula cited to administer fluid as rinses lactate or 5% extra. Position of the patient should be dorsal position. In susceptible cases, to minimize any adverse effects of vena cava compression, a 15-degree tilt to her left using a wedge till delivery of the baby should be done. Anesthesia. Anesthesia may be spinal, epidural or general. However, choice of the patient and urgency of the delivery are also considered. Antiseptic painting. The abdomen is painted with 7.5% povidone iodine solution and to be properly draped with sterile towel. Now incision. Incision on the abdomen. The surgeon may choose either a vertical or a transverse incision in the abdomen. Vertical incision may be infraumbilical, midline or paramedian. Transverse incision modified Fenton style is made 3 cm above the symphysis pubis. Now we shall tell some advantage and disadvantage of transverse incision. Advantages are postoperative comfort is more, Fundus of the uterus can be better palpated during immediate postoperative period. Less chance of incisional hernia and cosmetic value. Disadvantages are takes a little longer time and thus unsuitable in acute emergency. Blood loss is slightly more, reduce the competency during repeat section. Unsuitable for classical operation. Disadvantages of transverse incision. Now, packing. The Doyne's retractor is introduced. The peritoneal cavity is now packed off using two Dept large swabs. The tape ends are attached to the artery forceps. This will minimize spilling of the uterine contents into the gynae peritoneal cavity. Uterine incision. Peritoneal incision. The loose peritoneum of the uterovesical pouch is cut transversely across the lower segment with convexity downwards at about 1.25 cm below its firm attachment to the uterus. The lower flap of the peritoneum is pushed down a little. Make an incision on the uterine wall. The most commonly used incision is low transverse. Advantages are easy of operation, less bladder dissection, less blood loss, easy to repair, complete reperitonealization is possible, less adhesion formation, less risk of scar rupture when trial of labor in the subsequent pregnancy. Other types of uterine incision is lower vertical, classical incision, J-shaped incision, and inverted T-shaped incision. Low transverse incision. A small transverse incision is made in the midline by a scalpel at a level slightly below the peritoneal incision until the membrane of the gestational sac are exposed. Two index fingers inserted and extension of the incision done. This method minimizes the blood loss but requires experience. Alternatively, the incision may be extended on either side using a pair of curved scissors to make it curved down about 10 cm in length. Concavity directed upwards. Delivery of the head. The membranes are ruptured if still intact. The blood mixed amniotic fluid is sucked out by the continuous suction. The Doyne's retractor is removed. The head is delivered by hooking the head, with the fingers of which are carefully insinuated between the lower uterine segment and the head until the palm of the hand is placed below the head. The head is delivered by elevation and flexion using the palm to act as a fulcrum. As the head is drawn to the incision line, the assistant is to apply pressure on the fundus. If the head is jammed, an assistant may push up the head by sterile gloved fingers, introducing it to the vagina. The head can be also delivered using either Wrigley's or Burton's forceps. Delivery of the trunk. As soon as the head is delivered, the mucus from the mouth, pharynx and nostrils is sucked out using rubber catheter attached to the electric sucker. After the delivery of the shoulder, intravenous oxytocin, methergine is to be administered. The rest of the body is delivered slowly and the baby is placed in a tray placed in between the mother's thighs with the head tilted down for gravitational drainage. The cord is cut in between two clamps and the baby is handed over to the pediatrician. The Doyne's retractor is reintroduced. The optimum interval between the uterine incision and delivery should be less than 90 seconds. Interval more than 90 seconds are associated with poor Apgar scores. There is reflex uterine vasoconstriction following uterine incision and manipulation, removal of the placenta and membrane. Now, by this time, the placenta is separated spontaneously. The placenta is extracted by traction on the cord which is a simultaneous pushing of the uterus towards the umbilicus per abdomen. It is called control contraction. Routine manual removal should not be done. Advantages of spontaneous placental separation are less blood loss and less risk of endometritis. The membranes are carefully removed, preferably intact, and even a small piece, if attached to the decidua, should be removed using dry gauze. Dilatation of the internal os is not required. Exploration of the uterine cavity is desirable. Sutures of the uterine wall. The sutures of the uterine wound is done with the uterus keeping in the abdomen. Some, however, prefer to eventuate the uterus prior to suture. The margins of the wound are picked up by the green armatage hemostatic clamps or sponge holding forceps. The uterine incision is sutured in 3 layers. First layer. The first stitch is placed on the far side in the lateral angle of the uterine incision and tied. The suture material is number 0 chromic catgut or vicryl, and the needle is round body. A continuous running suture taking deeper muscles excluding or including the decidua. It is very difficult to exclude decidua. Ensure effective apposition of the tissues. The stitches is ultimately tied after the suture include the near end of the angle. Second layer. A similar continuous suture is placed taking the superficial muscles and adjacent fascia overlying the first layer of suture. Uterine muscle may be closed using continuous single layer stitch taking full thickness muscle and decidua. There is controversy as regard the place of single layer or double layer closure is in relation to risk of subsequent scar rupture. The peritoneal flaps may be opposed by continuous inverting suture. Non-closure of the visceral and parietal peritoneum is preferred. Now, the mobs placed inside the abdominal cavity are removed and the number verified, the peritoneal toileting done, and the blood clots are removed meticulously. The tubes and ovaries are examined, Doyne's retractor removed, being satisfied that the uterus is well contracted and abdomen is closed in layers. The vagina is cleansed, blood clots and sterile vulval pad is placed. Now, postoperative care. This postoperative care is divided into days as first 24 hours or day 0. Observation for the first 6 to 8 hours is important. Periodic checkup of pulse, blood pressure, amount of vaginal bleeding and behavior of the uterus is done and recorded. Fluid transfusion. Sodium chloride or Ringer's lactate drip continued until at least 2 to 2.5 liter of the solutions are infused. Blood transfusion is helpful in anemic mothers for a speedy postoperative recovery. Blood transfusion is required if the blood loss is more than average during the operation. Oxytocin. The injection oxytocin 5 units IM or IV or methotrexate 0.2 mg IM is given and may be repeated. Prophylactic antibiotics should be given for 2 to 4 doses. Analgesic is the form of pethidine hydrochloride, 75 to 100 mg is administered and may have to be repeated. Ambulation. The patient can sit on the bed or even get out of bed to evacuate the bladder, provided the general condition permits. She is encouraged to move her legs and ankles, to breathe deeply to minimize leg vein thrombosis and pulmonary embolism. Baby is put to the breast for feeding after 3 to 4 hours when mother is settled. Her condition is stable and relieved of pain. Day 1. Oral feeding in the form of plain or electrolyte water or raw tea may be given. Active bowel sounds are observed by the end of the day. Now, we shall discuss about the complications of Cesarean section. The complications are related either due to the operations or due to anesthesia. And the complications are grouped into maternal and fetal. Maternal complications may be intraoperative, postoperative. Intraoperative complication. Intraoperative complications are: number 1, extension of the uterine incision to one or both the sides. This may involve the uterine vessels to cause severe hemorrhage, may lead to broad ligament hematoma formation. Uterine laceration at the lower uterine incision may extend laterally or inferiorly into the vagina. Bladder injury is rare in a primary CS but may occur in a repeat procedure. Should a bladder injury occur, repair is done with a 2-layer closure with 20 catgut. Ureteral injury is rare. Injury occurs during control of bleeding from the lateral extension. Gastrointestinal tract injury is rare unless there is prior pelvic abdominal adhesion. Hemorrhage may be due to uterine atony, uterine laceration. Medical management should be started. Surgical management is done where there are wound laceration. Blood transfusion is needed. Morbid adherent placenta or placenta accreta is commonly seen in cases with placenta previa who had prior Cesarean delivery. Total hysterectomy is often needed for such a case to control hemorrhage. Now, postoperative complication. Postoperative complication is immediate and remote. Immediate complications are postpartum hemorrhage. The blood loss in Cesarean section is more often underestimated. It is mostly related to the uterine atony, but blood coagulation disorder may be rarely. Shock. While most often it is related to the blood loss. Anesthetic hazard. These are mostly associated in emergency operation. The hazards are related to aspiration of the gastric content. Infection. The common sites are endomyometritis, urinary tract infection, abdominal wound infection, peritoneal cavities, that means peritonitis, and lungs. Septic pelvic thrombophlebitis may be associated with endometritis. Risk factors for infection are prolonged duration of labor and that of rupture of membranes. Repeated number of vaginal examinations, prophylactic antibiotics reduces the risk significantly. Intestinal obstruction. The obstruction may be mechanical due to adhesions or bends or paralytic ileus. Deep vein thrombosis and thromboembolic disorder are more likely to occur following Cesarean section than vaginal delivery. Complication. One complication is abdominal wound sepsis is quite common. The complication with which are detected on removal of the skin stitches. Sanguinous or frank pus is common. Hematoma formation on the stitch. Dehiscence of stitch, vast abdomen involving peritoneal cord, and rarely necrotizing fasciitis. Secondary postpartum hemorrhage. Postoperative complications are grouped as gynecological, general surgical, and future pregnancy. Gynecological complications are menstrual excess or irregularities, chronic pelvic pain, or backache. General surgical complications are incisional hernia, intestinal obstruction due to adhesion and bends. In future pregnancy, the complications are there is risk of scar rupture. Now, the fetal complication. Fetal complications are iatrogenic prematurity and development of respiratory distress syndrome is not uncommon following cesarean delivery. This is seen when fetal maturity is uncertain. Accidental scalpel injury to the baby may occur. Maternal and perinatal mortality and mortality. Overall, maternal mortality ranges between 6 to 22 per 1,000 procedure, but with adverse patient profile and suboptimal circumstances which are often interrelated. The maternal mortality ranges from 0.1% to 1%. The causes of death are hemorrhage and shock, anesthetic hazard, infection, and thromboembolic disorder. Fetal. The perinatal mortality ranges from 5% to 10%, and the deaths are mostly related to emergency operations. And the complicating factors for which the operations are done. The causes of death are asphyxia, may be pre-existing, RDS, prematurity, infection, and intracranial hemorrhage. Extraperitoneal cesarean section was practiced in the past in cases with severe infection. Lower segment is approached extraperitoneally by dissecting through the space of Redsis. Currently, with the availability of potent antimicrobial agent, this is rarely performed. Cesarean hysterectomy. Cesarean hysterectomy refers to an operation where cesarean section is followed by removal of the uterus. The common conditions are morbid adherent placenta, atonic uterus, and uncontrolled postpartum hemorrhage, big fibroid, extensive laceration due to extension of tears with broad ligament, hematoma, grossly infected uterus, and ruptured uterus. These are all about the cesarean section. Thank you.